this is Tobias Trippel from the Young CVCT. We're here at the ACC 2016 in Chicago, and with us is Professor Cleland. It's a great honor to have you.
Great honor to be here.
Thank you. We're trying to go over 5 studies in a quick session, maybe 30 seconds each, 4 trials. And maybe you give us your insights, your interpretation of the results and possible impact. Vindicate.
Yeah. Okay, so we have the mixture of clinical trials here. As usual, disappointingly, many of the larger trials neutral at the meeting, but we have some small nuggets of gold with some smaller clinical trials, and also a reprise of some trials that we heard about some years ago that now have longer follow-up. So the first trial I wanted to mention was one done by a colleague, Klaus Witt from Leeds, who's been looking a lot at vitamin D deficiency in patients with heart failure, and he's shown that it's really quite prevalent. So this was a randomized controlled trial looking at vitamin D supplementation on symptoms, cardiac exercise capacity, and ventricular function. A study of around about 120 or so patients. And basically he showed that over, I think it was a period of about several months of treatment, that there was an improvement in ventricular function, ejection fractions was increased, and ventricular volumes were reduced, and ejection fraction increased, but unfortunately a non-significant increase in the walk test. But I think it does provide the ammunition to go forward with a phase 3 study to look at the real clinical effects and the impact on outcome. We should remember that vitamin D is not only important for bone mineralization, but also for cardiac myocyte function and also renal function. So it's not just the bone that matters with vitamin D. So, yeah.
So if you were to design at the CVCT, we think about how we can implement interesting clinical trial designs. If you were to go and follow up on this kind of trial, aside from an imaging endpoint, what would be for you the most relevant endpoint on a functional level?
Well, ask the patient, and it is about the patient's well-being, and there's a number of ways you can measure the well-being. That's symptoms and quality of life. And secondly, it's about the patient outcomes, so that's fundamentally prognosis. I think we're increasingly concerned about hospitalization as an outcome measure. Some people would perhaps want to expand that to include emergency therapy or need for intravenous outpatient therapy to, as it were, expand this changing heart failure hospitalization endpoint, because there are many strategies to stop a patient coming into hospital. The alternative, potentially much cleaner, is to take it on the chin and say that ultimately we want to know what the impact is on cardiovascular prognosis. So that would be the endpoint. So, but another philosophy is that we as academics and clinicians are looking for substantial effects. We're not really looking for small effects. If you're a commercial company with a very expensive research pipeline and program, and you absolutely have to make sure that you don't miss the opportunity of seeing a 15% reduction in mortality, that's fine. But how many pills can a patient take? And actually what we as academics are perhaps looking for are the large gains. So we don't need large trials to see those large gains. And I've argued that perhaps no trial of chronic heart failure, for instance, should be more than 4,000 patients, because, okay, you may get a p-value, but it might still be clinically irrelevant what you've found, that the magnitude of benefit is so small.
Looking at some other smaller trials presented at the Congress here, let's maybe take a closer look and a deep dive into Innovate-HF maybe.
Okay. Well, there's been more bad news for vagal nerve stimulation. We heard earlier about the Nectar study, which was run by Fayez Zanad, and that was neutral. We were hoping that with Innovate, with a different vagal nerve stimulation, perhaps more effects on heart rate and rhythm, that we might see more effects, but indeed none were observed. In a subgroup analysis, there really was no evidence of any subgroup that benefited. There was evidence that women potentially did worse than the men, but on a multivariable analysis, that really was probably just the play of chance rather than a genuine effect. But it just meant that the effect was neutral in men and worse in women. It wasn't that taking the women out of the equation, the men benefited. So really, back to the drawing board, I think, with vagal nerve stimulation, I think that it must put a question mark over further investment in this. I think that there are a number of companies that are still interested. It comes as a bit of a surprise to the cardiologists to find that the neurologists are using this as a treatment for epilepsy, and actually there are tens of thousands, if not hundreds of thousands, of vagal nerve stimulation implants every year for epilepsy. So clearly the technology is there, it's being used, it has a commercial value. The question is, can it be adapted for use for other diseases than epilepsy? But so far for heart failure, the answer is no.
Maybe we just jump to the next trial and try to focus on something that you, I know, also have a lot of experience with. That would be impedance to determine also body composition, these kind of actions, total body water. There is a new trial that just came out with very interesting results at the hotline session today, impedance HF. What are your thoughts?
Yeah. Well, this was a new impedance technique. They've really adapted the technology to overcome some of the limitations of previous bioimpedance technologies. It was a 2-center study, very long-term study, and really the investigators have to be congratulated on that. I suspect they enabled the long-term technology approach because it was so well integrated with the clinical practice. So really hats off to the investigators. They showed that if you provided the bioimpedance information to the treating clinician, then they were able to adjust the treatment, and that reduced hospitalizations and ultimately reduced mortality. The patients made measurements once a day with the device. It took I guess it takes them longer to put the device on and off. The actual measurements take 10 or 15 seconds, apparently. So it was questioned, why could an improvement in bioimpedance lead to a reduction in mortality? But actually, if you have better control of the congestion, if there's less fluid in the lung, that probably means that your atrial volume is smaller, your ventricular volume is smaller, and you wouldn't be at all surprised if there was a beneficial effect on ventricular remodeling if you control congestion better. And why not lead to a reduction in mortality? The flip side of the coin was that this was a 2-center study, limited number of patients, and we really have to sort of broaden it out into a much wider experience before we can be sure. So I would regard this as a highly successful phase 2 study, a bit like Vindicate. Now we need this gives us the argument for the investment in phase 3 in the way that Nectar and Innovate don't give us the argument to invest in phase 3 for vagal nerve stimulation.
Now, we talked about gold nuggets already. What is the fourth gold nugget that you found at the conference?
Well, the other one was Stitches, and Stitches was a study of coronary bypass surgery versus medical treatment alone. It did report its 5-year follow-up 5 years ago, and it missed its primary endpoint. It couldn't show that there was a reduction in all-cause or cardiovascular mortality at that time. But of course, once you've done the surgery, you can't take it away. So they followed the patients up for a further 5 years. Really have to be congratulated because they're lost to follow-up over the decade, despite the fact that it was an unplanned extension at the start. I can't remember exactly how many they lost, but it was only about 25 patients out of 1,200, which is an astonishing success. And they showed statistically significant modest reductions in mortality, which is going to have to make us think a little bit about the guidelines. Clearly, it does make us have to think carefully about what the role of revascularization is. As I say, it took a long time for the benefits to evolve. I think in a 70-year-old patient, their likelihood of surviving the 10 years to see that benefit might be quite small. On the other hand, for a 55-year-old with coronary artery disease, there might be quite a strong argument for revascularization.
Okay, thank you so far, Professor Cleland. Thank you for joining us,
Yeah.
and thank you for watching.